Alright guys, part 2 of the video series on the Neo patients. And now we're going to talk about, again, the distressed newborn. And I pray that you can go your entire career and never have one of these, okay? But again, when you do have one, that's his hero time, okay? So we need to determine a couple things. Again, premature infants usually end up in some sort of distress, okay? If they got fetal meconium at birth, they're usually going to be, it's a good indicator you're going to have fetal distress, all right? If they aspirate that meconium, again, Velcro in the lungs, can cause all kinds of major problems, and you need to make sure that you report any meconium directly to the medical physician, okay? You need to make darn sure to make a very good point of that. All right, so, again, very rarely do you, I would say very rarely do you need to ventilate or you need to oxygenate the patient, okay? When you do have to do it, though, again, 10% of the patients require a little bit of oxygenation and ventilation, okay? Again, use IV fluids, drugs, cardiac equipment is usually not used in the neonate. By the way, we do not, and I repeat, do not shove an IO into the baby's leg. The IOs are not indicated for babies less than 28 days of age. Reason is their bones aren't calcified. It causes problems. Don't do it, okay? Umbilical veins are fine, and we'll talk about those. And again, getting an IV started, it might be a little bit of a difficulty. I've heard some paramedics say before, well, it's okay to do it on them. No, it's not. Matter of fact, it's very much not okay. If you want to watch a neonatologist lose their mind, drop an IO on these kids, okay? So again, suctioning drying usually stimulates the distressed newborn. And again, fetal heart rate. Keep their heart rates up. Keep their heart rates up. If it's below 60, you should be doing chest compressions, okay? If it's 60 to 100 and they're not responding to ventilations, you should probably be doing chest compressions, all right? So, and then remember, make sure that you got all your stuff in your bag, know where it's at. I would set it out just in case I needed it. Laryngoscope. Zeros are for premature. Usually one blades are just fine. If they're before 35 weeks, usually we go to a 0 blade, okay? Uncuffed ET tubes, usually, guys, even a newborn at full term is like a 3.5 or a 4, okay? Only if they're before 35, that's when you start looking at these guys right here, the 2.5s, okay? In some services, they came to this thing where they now only carry one of each tube. I'm going to tell you why that is an idiotic move, but I will give you some tricks on how to get around that a little bit, okay? So, again, make sure you got your stylet. Make sure, again, I think that it's a very important thing. You're usually going to tape a tube with a baby. If you're going to have to tube a baby, it's very rare that you should ever have to, but I would use tape. There's no way I'm letting go of that tube. I'm sorry. Just if I've got the airway, when I say I have the airway, I mean I have the airway. You can use LNAs on these guys. They do make a king tube that small or an iGel that small. But again, it needs to be probably a size 0. Probably not the way to go on these guys. Usually, guys, an OPA works just fine if you have to do a resuscitation. 3-way stopcock, though, that is a huge piece of equipment that you should probably have, especially because you're going to be given really small doses of fluids and medication. So I would definitely have that there, okay? Again, your glucometer is going to be a 20 milliliter syringe with an 8 French feeding tube or gastric suction. Again, if they blow up their bellies because we bag them too much, you really need to drop an NG tube on these little guys. And it doesn't take much, by the way. If you're going to use epinephrine, you're going to be using literally 0.3 of 1 cc probably. Somewhere between 0.3 and 0.5. You should be using a 1 cc to pull it up using that 3-way stopcock, and hopefully they'll show you how to do some of these things in labs. All right, you drew the bad straw, and you get a distressed newborn. You're going to have to do a resuscitation. All right, so this is how we're going to do it. Again, they come out, you dry them, you warm them, you position, tactile stimulation. Guys, that right there is 95 to 96% of all of it. Every now and then they come out a little bit bluer than you expect. Put them on a little bit of blow-by oxygen, okay? Just a little bit. You don't have to go crazy on this. Give them a little bit of supplement. They'll pink right up almost immediately, okay? If they're having trouble with their breathing, if they're not pinking up, if the heart rate is slowing down more than it should, that means below 100. Start bagging them, okay? And if they get below 60, you should be doing chest compressions. If you're bagging them and they're still below 100, you should be thinking about doing chest compressions. Guys, what I just explained in this basic life support, which requires no paramedic knowledge at all, is 99% of all neonatal resuscitation efforts, okay? You may have to intubate a child. It's very rare, but you may have to, especially if they're meconium stained. That's probably the only reason that you would do so, and you think that you can get the meconium out before they take the breath, okay? And then last but not least is the medication use, and that's going to be our epinephrine, 0.01 milligrams per kilogram, okay? You should be drawing this up in a 1 cc syringe, okay? It should be that small of amount of epinephrine that we're going to be giving these little ones, okay? So, keep these things in mind as you start to do it, all right? If resuscitation is required, okay, and they have taken their first breath, or we've gone more than probably 30 seconds, clamp the cord. I know that in the last video I kind of said you can leave them attached to the mothership. If the cord is still pulsating, that is true. However, most of the time, if you're having to do a resuscitation, it's probably a better idea to go ahead and start bagging them. And if they don't immediately take that breath, go ahead and cut the cord and get the baby where you can work on it, okay? Problem is where you don't want to be doing a neonatal resuscitation is between mom's legs. That's a really, 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 really bad idea that's going to lead to all kinds of chaos, all right? So, again, when we do a neonatal resuscitation, don't think of the 2-minute standard resuscitation that we would use for PALS or for ACLS. Think of it as in 30-second blocks. Drying, tactile stimulation, 30 seconds. If they're not responding to it, begin ventilations for 15 to 30 seconds. Reassess where you're at, okay? If that doesn't do it, the heart rate is now slow. Again, notice that they're reassessing at the umbilical vein. Again, we should probably have stickers on. Check the brachial pulse. And again, if the heart rate's not good, again, that was below 60, start chest compressions, okay? Do 30 seconds of it, see where you're at. And remember, in neonatal resuscitation, it's a 3-to-1 ratio. 1, 2, 3, bag. 1, 2, 3, bag. 1, 2, 3, bag. Okay? So if it's 60 or above, you can discontinue chest compressions. I put a little caveat on that, guys. 60 and above, and the heart rate's going up, then you can stop it. If you're still at like 70 and the heart rate's not getting better, I would keep doing compressions. Okay? And that's a neonatal resuscitation standard, okay? So again, reassess every 30 seconds. If they're not then responding to chest compressions and bagging, you need to intubate the baby. Maybe some direct oxygenation might help. And if that doesn't work, then you're going to start giving medications. Again, epinephrine is the key one there. If the mom has any type of narcotic overdose, I would be thinking, or drug use, try to find out what those drugs are. More than likely a narcotic that's causing it. And again, then you can give naloxone, but again, a very small amount of naloxone. Refer to your Broslow tape on that. All right. Again, make sure that when we're doing it, again, you still got to get that APGAR score. I can probably tell you right now, gang, you're probably going to be you're kind of putting those little steps together afterwards. Again, but again, the biggest thing is what's the respiratory effort? What's their heart rate? What's their color? Okay. If you can assess those 3 things, you're already way ahead of the game. All right. You should begin positive pressure anytime that the heart rate is less than 100 beats a minute. If there's any signs of apnea, if you have any SpO2 that's less than expected, in other words, you've given some oxygen and they're not getting better, yeah, probably good. If you got persistent central cyanosis, yeah, good time to bag these kids, okay? Remember that the rate should be about 40 to 60 a minute. And guys, when you are bagging them, a little puff, just a teeny tiny puff, that's all they need. Barely squeeze it, barely, okay? Just enough to see the chest rise. That's all you need to do. Don't go squeezing with the whole hand. if you go squeezing with the whole hand, you're going to inflate their little tummies. When you inflate their little tummies, then you're going to have to probably put an NG tube down to drain out that air. Okay, so just don't do it. All right. So again, make sure that your face mask fits correctly. I can't stress that one enough. If you've got a neonate, you're probably going to need, if you've got a premature birth, you're going to need an even smaller bag. Okay. Don't try to bag them with too big of a, again, if you directly oxygenate their little retinas, yeah, you're probably going to blind them. Okay. Not a good idea. All right. If you do have to endotracheally intubate them, make sure that you got your meconium aspirator. Make sure that you got, if the prolonged ventilation is going to be needed. Guys, Dr. Frank is huge about not intubating babies. I am intubating a neonate. I too am 100% about that. I think that we are going to cause a lot more harm than good. There needs to be really good reasons for us to do it. Meconium staining, I would say, is maybe the only thing in the pre-hospital setting that remotely, and it needs to be done by the person who's got the most experience with it. Okay, usually put an OPA in and bag them. As long as the air is going up and down, as long as that little chest is going up and down, you're oxygenating them. That's all that's really required. Okay, so again, one of the things about intubating these little guys, okay, put that little pad behind their head. Remember that they have no teeth, but again, it's a little bit, their anatomy's a little different. Line up that ear, the hole in the ear with the shoulder, okay? Line it up so that you have a better look, okay? And remember, it's going to be tight quarters in there, okay? It is going to be super tight. If you get this much room, I would be doing a jig and be happy, okay? Because it's not going to look like that. I assure you it's not, okay? Again, this guy's actually going down the tunnel. Sometimes you have to do that in the neonatal. It's okay. But again, once you remove the laryngoscope, man, there is no way I'm holding on to this tube. Check your tube placement just like normal. But the key thing is with this guy, look how much, this is literally maybe 1 centimeter in the lung. Okay, gang? This baby, you turn the head, you hit the wrong bump. More than likely, it's coming out, okay? I know with the Neo team at Shands, we spent forever making sure the tube was secured, and you constantly was checking that tube when you're in transit, okay? So again, the resuscitation, you usually use an uncuffed endotracheal tube. These little guys' airways down here, extremely pliable still, and if you put pressure against them, you will cause necrosis. So don't do it. Intubation bypass glycat function eliminates the need for positive inexpiratory pressure. That's the good news about doing an intubation on them. But again, if gastric detention is present, just drop an NG tube or an OG tube and deflate the lung, or deflate the stomach, okay? And again, if the central cyanosis is present, again, supplemental oxygen. Again, titrate your oxygen to a saturation of between 95 to 96%. You don't got to go 100% on these gas, okay? Don't do it, all right? And oxygen should be warmed and humidified if possible. Again, we usually don't have that in the back of the truck. I know the Neo, it was always warmed and humidified, okay? Compressions, I talked about this a little earlier. 3-to-1 ratio is our key thing if it was below 60 beats a minute. And again, the goal is to get 90 compressions and 30 breaths per minute, okay? That's our goal there, all right? So coordinate your chest compressions and your ventilations, and then discontinue once the heart rate exceeds 80 beats per minute. And it should be because it's going up, okay? I can't stress that one enough. It should be going up. All right, so you're, again, it's usually 99% of these is due to hypoxia, okay? Ventilate and oxygenate them. Imagine this, the babies come right around, and it's like a miracle. It's magic, okay? They literally start doing so much better, okay? They really do. All right, so this is where we're looking at the umbilical cords and the umbilical veins, okay? Remember, the umbilical arteries do not have oxygenated blood. Remember, it's opposite of what, and then the umbilical vein is usually the big red one in the middle. It does carry oxygenated blood. So remember, guys, this is the one that we want to cannulate, okay? So if we're getting circulation. We're going to make a fresh cut on this cord. We're going to then insert our catheter, usually the longest one I got. Hopefully you've got an umbilical catheter that you swiped from somebody on the truck. So remember that there's a little sphincter right about there. And so you really need to get it past that point, okay? So make a fresh cut. Again, insert. I use the twist tie usually that's in the bag to kind of form a seal so that the fluid's going into the baby and not into outside of where it should be going. Again, you should be using a 5 French umbilical catheter. That's what we should be using. And again, most people don't have that. And then connect your catheter to a through-way stopcock. Make sure that you fill it with saline before you start pushing the fluids through it. Same way with a 14 gauge. If you use a 14 gauge catheter, you really should fill it with saline first and then insert the catheter. Take the needle out, put your 14 gauge, fill it full of saline, and then insert it into that spot. Okay? You just want the plastic part, not the needle. Okay? Now, mom used narcotics, and they usually have low birth weights, and they will actually have withdrawal symptoms. And again, resuscitative measures might be required. We might need to give them Narcan. Guys, 0.4 is a lot of Narcan for these little ones, okay? So refer to your Broslow tape. Definitely get med control involved. Now, a neonatal transport, if they are from 0 to 28 days, and it is a hospital-to-hospital transfer, hey, guys, I got some great news for you. Some absolutely wonderful news. And I don't care what doctor tries to buffalo the hell out of you and say that you are required to take them. Allow me to bust their bubble. No. If it is from hospital to hospital, it requires a specialized neonatal intensive care in the state of Florida. There is nothing that can override that. If it's an emergency room, they are supposed to have all of the equipment to manage that patient until a NICU unit arrives, okay? So, long and the short, usually they have a pediatric respiratory therapist and a pediatric nurse on these, okay? They will accompany them. You are neither, okay? I know Shan's Neo team, we have a nurse, and usually the nurse is usually a nurse paramedic or a respiratory therapist paramedic. Is usually what's on the team, okay? So again, usually your driver is the paramedic, so just in case weird stuff happens, all right? So, again, they are required to go by a specialized transport unit. If they tell you, hey, I'm going to, you have to take them. No, you don't. Okay? I don't care what they say. Get your supervisor involved. Get everybody involved. Yeah, long and short, no, this needs to go by a NICU. Okay? It needs to go by a special pediatric team. Okay? You don't have one of these guys right here, which is an isolette, which maintains the warmth, maintains the humidified oxygen. Again, this is what you need in order to transport these babies, okay? We can't, and even then, critical care trucks, unless they have the specialized training, the answer is no, you shouldn't be taking them. It is required in the state of Florida. A neonatal transport unit is the one that actually does this. All right, we're going to leave it here. This is going to start the third part. So, again, the takeaways from this, CPR, 3-to-1 ratio. If the heart rate's less than 60, definitely. If it's 60 to 100 and not increasing, make sure you bag them. Make sure, again, it's okay to give them chest compressions even then, okay? Need to make sure that you don't get buffaloed into transporting one of these little guys. If it's from a scene, you can. Hospital to hospital needs a specialized neonatal intensive care mobile unit. Do not take them. End of story. All right, guys, we'll see you on the next one.